I mean, I'm talking absolute layman terms. Okay, let's get to wounds. But they have different kind of wounds. It sounds like the easiest thing, but there have been MCQs on this in the AIMS paper as well. All of you must have seen those stab incision, slash incision and all that. You know, simply imagine dramatic movies. Okay, you'll understand wounds very easy. Incised wounds, remember doctors. Okay, with a scalpel or a blade you take and you place an incision, that is going to be an incised wound. So what you're going to have is you're having a clean wound over there. You're using a sharp object to produce it. And it's easy to manage such cases because you can just do primary suture to it and you can expect good healing. So that's an incised wound. Now this is, of course, I'm talking about doctors using a scalpel or a blade, but any sharp object, even in normal scenarios, can produce an incised wound. Now look at a lacerated wound. Take any blunt object and scratch, right? You're going to produce a laceration wound. Scratch is not superficial. I mean, scratch is going to be an abrasion. It will be superficial. But when I talk of laceration, we're dealing with a little more deeper tissue, but it is produced with a blunt object. So you're not expecting the margins to be sharp, and you're not expecting it to be clean. Take any blunt object and try to pierce your thing with it. Your margins of the wound are going to be irregular, jagged, contaminated, right? So this requires that you do a little toilet of the wound, that is you need to clean the wound and then suture it. You need to understand these causes. This has also been an MCQ. A sharp object producing an incised wound, a blunt object causing a lacerated wound. So these kind of MCQs do come. Now come penetrating. Penetrating is done in case of stab injuries. Chaku lege ghusadna. Matlab, it's push. You know, you're causing a penetrating injury. Okay. Now let's talk about crushed or confused. This is a blunt trauma. This can cause confusion. So here you have edema, bleeding within the facial compartment. So there's ischemia of the muscles and the nerves. This requires a good debridement. Okay, there are some more things we're missing over here. Abrasion, I already told you what it is. No space. I'll write that here. Abrasion is just a superficial loss of the skin. Alright? Then, what else do we have? What are the other kind of injuries? We've seen laceration. Any other thing that you can remember of? Concussion, contusion, okay. Slash wounds. Yeah, okay. Slash, it's actually not a type of wound actually. The only thing you need to understand about slash is it's going to be longer in, more lengthier and less in width. It's not going to be deep. A stab wound is going to be deep. These are of course non-medical terms, but Dara, you were confused about this earlier also. I'll tell you it. A stab is going to be greater in depth, less in length. Understand? Yeah. Now, difference between an abrasion and a laceration. In abrasion, do we have any break in tissue continuity? Forget about whether it is a sharp wound, sharp object, blunt object and all that. A laceration is something where there is going to be a break in the continuity of the skin. Okay, you are going, both abrasion and laceration will be restricted to the skin portion itself. When you go to slash and stab, you're going to the underlying connective tissue, you're going into the muscle and all that. But when we talk about these two conditions, we restrict ourselves only to skin. But the only difference lies in whether the skin has broken its continuity or there is no continuity in the break. Okay, when you talk of an abrasion, when it is a simple scratch, you say that there is a superficial damage to the skin and you're only going to have a loss of epidermis here and there. Okay, but when you talk of laceration, you may be breaking the continuity of the epidermal portion altogether. You may be in the dermal portion of the skin. Yes, you are in the skin. Okay, but there is going to be a little more depth. Saurav is helping you with some diagrams. Okay, let's proceed. Next, we have repair. We have regeneration, reconstitution and repair. One second. Okay, regeneration is when some amount of the lost tissue is going to be replaced by a tissue which was, like suppose one type of tissue is lost, the same type of tissue will be replaced by specialized cells. So it's regeneration. Reconstitution is there is coordinated regenerations of several types of tissue. Now see, for example, in one organ you're going to have skin, connective tissue, muscle, and all those three types of tissues are being replaced. That is reconstitution. And that is little difficult in humans. Okay? Maybe possible, may not be, I'm not sure, but that's common in lizards in reconstitution of the tail. So you have different types of tissue being replaced. Repair is where you have replacement of lost tissue by granulation tissue. So here you have fibrosis, you have scar tissue formation and all that. Suturing of the wounds. Primary suturing, all of us know this. This happens when there is a, I would say 6 hours. I would go with 6 hours. That's what I have read. 6 hours would be my answer. This is done in incised wounds. It's important that when you're doing a primary suturing, you want the margins to be clean and you want the margins to approximate. You need them come too close together. Only then you can do a primary suturing. My answer is 6. And suturing, when it is done within 6 hours of injury, also is primary suturing. Now, delayed suturing, we have, or in primary suturing itself, you have delayed primary suturing. This is done in case of lacerations and contaminated wounds. Here you require some amount of wound debridement and toileting to be done, and you examine the patient after 4 to 6 days and then do the suturing. So it's a delayed primary suturing. Then we have secondary suturing. This is done after 2 weeks. These numericals, is very important. A secondary suturing is when there is a wound that has been left open and when it is also has a lot of debris, it needs dressings and it needs antibiotics. So such kind of thing is secondary suturing. Delayed primary suturing is when it happens in case of lacerations or when the wound is contaminated. When a wound needs debridement and it needs some toileting, you do that, call the patient after 4 to 6 days and then suture the cavity. Suture the incision. That's called as a delayed primary suturing. It is still primary because your wound can be approximated. It's only contaminated, so you delay suturing it on the same day because you're scared you'll probably cause an infection at a later date. Then understand difference between a hypertrophic scar and a keloid. Hypertrophic scar is any wound, if left, can develop into a hypertrophic scar. It is non-familial and has nothing to do with a racial discrimination or anything like that, and it does not spread to the adjacent tissues, and this type is more common on the flexor surfaces. While a keloid can continue even after 1 year. A wound happens especially common in the black and has a familial discrimination. It has a spreading type of condition, and it is when it happens after the wound, it can form even after 1 year. So the difference between the two types of scars is important. Clear? It's not stuck. I'm there. Now we go to sinuses and ulcers. What is the sinus? A blind tract extending from an epithelial surface to a surrounding tissue is called as a sinus. We have two types of sinus. One is called as the congenital. Your preauricular sinus is the congenital type, a very important MCQ. Then we have acquired sinuses. There are different reasons for acquired sinuses. Tubercular happen to be the common, and tubercular type of sinuses are common in the neck. MCQ again. Median mental sinus, osteomyelitis, actinomycosis, all of these can cause acquired sinuses. All of you know what is a sinus, right? You can see a diagram here. This is a sinus. Diagram A is a sinus. Diagram B is a fistula. A fistula is when there are two epithelial surfaces and it establishes an abnormal communication between them. A fistula again can be of two types. It can be congenital or it can be acquired. Congenital means branchial. Examples again very important MCQ. Acquired is thyroglossal and parotid. Both are epithelium. Both are between the epithelial surfaces. Only thing is, a sinus is only an opening from one surface, one epithelial surface, while a could actually be extending between two surfaces. See, this is one epithelial surface and this is a second epithelial surface. So you see a tract running between the two, that is going to be a fistula. This is a sinus. The sinus is a blind tract. Clear? It need not be always. Dhana zaruri nahi hai. Okay, next. Then locations. You can have, see, it depends on the type of the cyst. If it is a branchial cyst, all of us know where, which is the most common site for the branchial cyst. In the anterior border of the sternocleidomastoid muscle, a very important MCQ. And the location can be helping you in diagnosis of the cyst. Fistula, sorry. Then comes the thyroglossal fistula, is going to be in the midline of the neck below the hyoid bone. Ulcer is a, all of you know what an ulcer is. An ulcer has different things. It has a margin, it has border. Margin is a junction between the normal epithelium and the ulcer. Then it has a floor. Okay? The floor is, when you see an ulcer, what you actually are seeing, right on, sitting on top of the normal skin, is the floor. Now we have different types of floors according to the type of ulcer, and this is a very important source of MCQ. Okay? A healing ulcer will show on its floor granulation tissue. Are you guys able to follow me? We are talking about the different types of floors and the type of ulcers that they are seen in. So if you see granulation tissue in the floor of the ulcer, means that it is a healing ulcer. If you see necrotic tissue, it is spreading type. A washed leather slough is seen in syphilitic ulcer. Apple jelly granulation tissue is seen in tuberculous type MCQ. In fact, all of these have come as MCQ. And if you see a black mass on the floor, could be a malignant melanoma. Okay? Clear? Then edge. Edge is what is between the floor and the margin. Margin was what? Junction between the... I mean, you can have a look at any ulcer. If you think of your general surgery times, visiting your patients in general surgery and you have seen a huge ulcer over there, that will be a floor. What was the margin we were talking about? Margin is the border between the normal tissue and the ulcer. What is in between the margin and the floor is going to be the edge. Okay? So in between that will be the edge. Yellow color is edge. What are the different types of edges we have? Very important here for MCQ again. A healing ulcer and a venous ulcer will show sloping edge. All of this is floor. A healing ulcer and venous ulcer will be sloping. Tuberculous will be undermined. Syphilitic and deep trophic punched out. If it's carcinomas, especially a basal cell carcinoma, will have a rolled out and a raised pearly white beaded edge. Remember these words, important. A squamous cell carcinoma will be raised and everted. Okay? Induration. Induration of the edge is also characteristic of squamous cell carcinoma. Induration means a little thickening will be there. Thick and firm. That's induration. That will be, the edge will be thick and all that will be in squamous cell carcinoma. Then we have a base. Base is on which the ulcer is resting. Okay? So below this yellow colored thing is going to be the base. The area on which the ulcer rests. So the base is indurated in case of squamous cell carcinoma. Are you guys with me? Able to follow me so far? Is it going okay? Alright. Next we go to the different types of ulcers. Just check, this is there in your keynotes, right? I'm sure it's there, but kind of just keep checking, alright? We have the venous ulcer or the varicose ulcer, which is the commonest ulcer that you see on the leg. More commonly seen, on the leg means where do you see it? It's on the medial side, and these are usually painless, but you will find a pigmentation. Then arterial will be ischemic, okay? Commonly seen in the tips. These arterial things happen usually on the last bit of the tissue, like if it's the digits and the fingers, in the terminal most portion because of a lack of blood supply and ischemia, they turn, end arteries, so they turn painful, and you will not find any pigmentation here. So that's how it can help you differentiate whether it is a venous ulcer or an arterial or an ischemic ulcer. Venous will have pigmentation, arterial will have no pigmentation. So as I explained to you, the reason for it is inadequate circulation, and inadequate circulation becomes of atherosclerosis. Then comes tropical ulcers. Tropical ulcers is caused by Vincent's organisms. Can you all tell me what are Vincent's organisms? When we talk of Vincent's organism, which organism we are referring to? Very good. Fusus pyroketosis. Very good. Okay. So it's a phagedenic ulcer. Means it kind of eats up. The edges will be undermined and you will have some copious serosanguineous discharge. Serosanguineous means almost a watery, dilute kind of discharge, which is copious. So large volume, and it's a very painful ulcer. Then comes Martorell's ulcer. Where do you see Martorell's ulcer? And these different types of ulcers are very important. It was described by Martorell in 1945, usually seen in hypertensive individuals or in the elderly. So hypertension is the key word over here. Then comes neurogenic ulcer. Neurogenic means nerve is affected. Nerve is affected, where is the chance of a pain? So it's a painless ulcer. And why there is an injury to the nerve which results in that ulcer formation is, there is a repeated injury. Okay, you take one area and continuously put pressure on it or continuous injury to it, the nerve is lost, loses its ability to perform normally and gets destroyed. Okay, so the pain sensation from that area is lost. Now where do you see such kind of scenario? Diabetes, alcoholic neuritis, Tabes dorsalis, spina bifida, paraplegia, or even in the peripheral nerve injury. So in these conditions, you will see a neurogenic ulcer. Trophic ulcer. We have seen two things. We've seen tropical ulcer and now we are seeing trophic ulcer. Don't get confused. Be very careful when you're reading that word in the exam, alright? A trophic ulcer is a variation of the neurogenic ulcer and MCQ. Example of this is a bed sore. And this also happens because of repeated trauma. You know what happens in bed sore, right? The patient is bedridden, so he lies in one position all the time. So there's constant pressure that's being applied to the buttock region or the back region, and a change of moisture plus a change of position, the patient tends to develop ulcer. Got it? What guys? With me or not? Yeah. Then comes traumatic ulcer. Now when I say traumatic ulcer, the first thing we think of is, remember your denture related ulcers or dental ulcers, plaster sores. Plaster sores is after the fracture that happens. Those kind of things will be traumatic ulcers. We know a lot of them. I mean a lot about them. So they're small, painful, circular. Okay, let's look at footballer's ulcer. Footballer's ulcer is a chronic ulcer caused by staph aureus, okay? It happens in an infection in an area of repetitive trauma. In the region where these guys usually kick the ball, that's called trauma to that area. So these people will develop a bacterial infection over there, which can transform into an ulcer. So that kind of an ulcer is called as a footballer's ulcer. Okay? Then comes Bazin's ulcer. Bazin's ulcer is seen in young, obese females. It happens because of ischemia, also related to Raynaud's disease. Another term, Marjolin's ulcer, is an ulcer that happens in squamous carcinoma. A squamous resulting in a scar forming an ulcer is called as a Marjolin's ulcer. Be familiar with all these different type of ulcers. They are very common source of MCQ in general surgery. Then comes Melanese ulcer. See, there are three types. You have Marjolin. Then there is Martorell. And then now there is Melanese. So 3 M's, and be careful with all of these. Where do you see Marjolin? Marjolin's ulcer. Where do you see Marjolin's ulcers? Come on. Okay, a squamous cell carcinoma converting into a scar. Martorell's ulcer is seen in hypertensive patients. Melanese, we will be looking into what it is. It's an aldermined ulcer seen in post-operative wounds. It's happening as a result of a symbiotic infection of microaerophilic streptococci and hemolytic staph aureus. So yes, combined bacterial infection, so it's seen in post-operative wounds. That is Melanese ulcer. And the kind of ulcer that it is going to be is an undermined ulcer. Diabetic ulcer, commonly seen again in diabetic patients because of ischemia, diabetic atherosclerosis. Commonly affected is toes and feet. What is the local treatment that you will do for ulcers? There's a term called USOL. USOL stands for Edinburgh University Solution. Edinburgh University Solution. It contains boric acid and bleaching powder. Okay. How much it is recommended these days, I have no idea. Then there is magnesium sulfate ointment. You can use alginates in bleeding wounds, so they will help in stopping the bleeding. Can you guys hear me? Okay. Then there is tegaderm, which is polyurethane membrane. So it prevents water loss from the ulcer. This is a local treatment. Of course, there can be antibiotics if it is infection.